Hi everyone, thank you for watching this video on a review of pertinent drug information for SARS-CoV-2 by the Society of Infectious Diseases Pharmacists. My name is Greg Cook and I am a pediatric ID pharmacist at Children's Hospital in New Orleans. Today I'm going to discuss pediatric considerations for the use of various medications being discussed for treatment of SARS-CoV-2. Starting out, the first medication we're going to talk about is remdesivir, or GS5734. So remdesivir, its mechanism of action is through the interference with viral RNA polymerase. So it's a viral RNA polymerase inhibitor, and this leads to premature termination of the viral RNA transcription. Remdesivir is just investigational at this time. It's available either through a clinical trial or through compassionate use via Gilead, which is currently limited to pediatric patients and pregnant patients. Some of the pharmacokinetic highlights of the medication: so remdesivir is a prodrug that's actively converted to its active metabolite. It's also it's also thought to be a CYP3A4 substrate, but currently at this time it's not thought to have a lot of risk for 3A4 drug interactions. Its active metabolite is 20.4 to 25 hours long, so this does support less frequent dosing. And then it is eliminated 63% renally, but currently there's no published renal dose adjustments or hepatic dose adjustments for the medication. Remdesivir's dosing for adult and children greater than 40 kilograms is recommended to be 200 milligrams on day 1, followed by 100 milligrams Q24 for the days after that. For children less than 40 kilograms, the recommended dose is 5 milligram per kilogram on day 1, followed by 2.5 milligram per kilogram Q24 for days 2 through however long treatment is. This dosing is recommended for patients that are at least postnatally aged to be greater than 7 days, that are full term, and for patients that have a serum creatinine less than 1. Per the World Health Organization, this pediatric weight-based dosing is expected to maintain comparable exposure of the medication similar to adult patients. And they made this statement in regards to Ebola virus dosing, so the weight-based dosing is expected to compare to adult dosing. Does remdesivir work? So I think the jury's still out on that. So this is some of the early compassionate use data in the adult population. So there was no comparator arm in this study. They were just looking at the patients that received compassionate use remdesivir for COVID-19. So they looked at 53 patients. The median age was 64 years old. And what they found were that patients that received the medication, 68% of them showed clinical improvement. But ultimately, without any comparator, we really need better data to really determine the medication's efficacy. And right now, even though this medication can be acquired and used in pediatrics, there isn't any pediatric data to support the use of the medication, even though you can get it via compassionate use. For the safety data for remdesivir, from that same adult compassionate use study, 60% of patients did have reported adverse events, the most common adverse event being increased hepatic enzymes, which is something that's recommended to monitor for while patients are on the medication. Other adverse events included diarrhea, rash, renal impairment, and hypotension. Ultimately, without a comparator arm, this is all confounded by COVID-19, so it's difficult to really tease out the risk of these adverse events with remdesivir. Given that remdesivir was also studied for Ebola, in that trial it did include more pediatric patients. For the adverse events in that trial, only one patient developed hypotension during the loading dose of the medication. And similarly to COVID-19, the confounding variable here was Ebola virus, so it's difficult to tease out if hypotension was from Ebola virus or was it from remdesivir. But it is currently something to watch out for when we're given those loading doses. Moving on to the next medication we're going to discuss for coronavirus, which is hydroxychloroquine. So hydroxychloroquine is an antimalarial and immunomodulatory agent with therapeutic potential for COVID-19. Its current mechanism of action is via impaired viral receptor glycosylation and intracellular alkalization, which inhibits viral replication. It's also thought to reduce some cytokine production and inhibit toll-like receptor signaling, which also might have a role in its treatment of coronavirus. Currently, the medications routinely used in pediatrics for various rheumatologic conditions, as well as from time to time for malaria patients. One of the challenges with hydroxychloroquine for the treatment of COVID-19 is how do we dose hydroxychloroquine appropriately for that indication. So currently in pediatrics for rheumatologic conditions, recommended dose is between 3 and 5 milligram per kilogram per day, divided in 1 to 2 doses. This division in doses is primarily done because if you give the medication in more frequent, so if you give it twice a day, you might be able to reduce some of the GI side effects of the medication. Whereas if we give it once a day, you might see those side effects more commonly. The recommended dosing for malaria is a larger loading dose of 13 milligram per kilogram, then a step-down dose of 6.5 milligram per kilogram at select hourly intervals after that, so at 6, 24, and 48 hours after that first dose. Then when it comes to hydroxychloroquine for COVID-19, there have been 2 PK analyses done on hydroxychloroquine. The first was by Yao and colleagues. They did a PK analysis that was on adult patients, simulations only, and essentially what they recommended was 400 milligrams twice a day on day 1, followed by 200 milligrams twice a day on days 2 through 5. There wasn't any sort of pediatric-specific simulations, but the estimated dosing in pediatrics to mirror that adult exposure would be 6.5 milligram per kilogram twice a day on day 1, then 3.25 milligram per kilogram twice a day on days 2 through 5. Downs and colleagues performed another PK analysis on hydroxychloroquine with adult and PK simulations, and essentially the pediatric dose that they were recommending is the same thing as the malaria dosing currently used, so mirroring that high loading dose, then a 6.5 milligram per kilogram dose thereafter. This is some additional data from the Downs and colleagues paper, so that orients you to these different figures. The blue line is the median, the dotted red lines are the 97.5 and 2.5 percentile. So figure 1 there is representing a 200 milligram 3 times a day dose for 10 days, and given that there's no loading dose there, you see the increased concentrations as time goes on. Figure B is the regimen recommended by Yao and colleagues, the 400 twice a day, and then 200 twice a day on days 2 through 5. Figure D on the right side of the slide, this is the 13 milligram per kilogram once, and then 6.5 milligram per kilogram at 6, 24, and 48 hours. So here, this figure representing that much higher level achievement with that high loading dose. And the authors conclude from this analysis that given that there's no known pharmacodynamic target associated with clinical outcomes, no specific recommendation can really be made at this time, simply based on simulations. They also go on to state, though, that the dosing recommended in figure D, or the malaria dosing, the 13 milligram per kilogram, and then 6.5 milligram per kilogram, that dosing rapidly optimizes blood and thus lung tissue concentrations, and if we give the medication at that high dose, it's going to sustain the concentration for short course therapy. What is hydroxychloroquine's safety? So the safety data for hydroxychloroquine, so the medication has been associated with retinopathy with chronic use of the medication, so likely not going to be too big of an issue in coronavirus treatment. It's also been associated with causing rashes, hypoglycemia, so something to watch out for in diabetic patients. Gastrointestinal disturbances is another adverse event. This is something that if we break the dose up into multiple doses over the day, it might be a little bit better tolerated, but that's also going to require more nursing and administrations and something to be aware of there. And then another one of the adverse events the medication can cause is QTc prolonging, and this is something we definitely want to watch out for when patients are going to be on multiple other QTc prolonging events or agents. What is QTc prolonging in children? So prolonged QTc is generally defined as a QTc greater than 450, and then severely prolonged QTc is greater than 500, or an increase of 60 from the patient's baseline value. Can we give hydroxychloroquine to someone that can't take tablets? So currently the answer is yes, but we have to make the medication into a suspension. So the package insert recommends not to crush the tablets. There are multiple different suspension recipes available on the internet for patients who cannot take the tablets. Essentially, they just involve removing the film coating on the tablet, and then they can be crushed and put into suspension. So the reference from McHenry and colleagues down in the bottom here provides some stability on the suspension recipe for anyone that is interested in that. The last piece about hydroxychloroquine I wanted to comment on is its combination with azithromycin. So azithromycin in pediatrics, when it comes to community-acquired pneumonia, it's not indicated unless there's a strong suspicion for an atypical bacteria causing that infection. So given that in pediatrics there's no data on the combination to support its use, it's worth warranting that there could be potential harm from this combination to be aware of if it was routinely used, and that you might see an increased risk of QTC prolonging, giving two different QTC prolonging agents, as well as giving azithromycin to a lot of these patients might increase the risk of antibiotic resistance. The next medication we are going to discuss for coronavirus 19 is lopinavir/ritonavir. This is a medication routinely used in pediatrics in the past, more so for HIV. Lopinavir is a protease inhibitor. Ritonavir is also a protease inhibitor, but when it's given in combination with lopinavir, it's acting more as a CYP3A4 inhibitor that's increasing lopinavir's concentrations. Then, in this case, lopinavir is thought to inhibit the protease of SARS-CoV-2, which inhibits viral replication. Does lopinavir/ritonavir work for COVID-19? So this is some adult data, an adult randomized trial. They compared 199 adults with severe COVID-19 randomized to either lopinavir, ritonavir, or standard of care. And you can see in the top figure here that there was no difference in the cumulative improvement for these patients. And then in the bottom figure, there was no difference in the patient's viral load. So ultimately, the authors of this study concluded that in hospitalized adult patients with severe COVID-19, no benefit was observed with lopinavir/ritonavir treatment beyond standard of care. This study wasn't a perfect study. There's multiple different biases reported in this study and issues with the study that you could come up with. One of the ones being that patients were started on treatment very late. So it's really difficult to determine if this medication works or doesn't work for COVID-19 with the current evidence base published, but it is just something to be aware of that currently there wasn't a reported benefit in this study. And then, of course, looking at the pediatric population, there isn't any evidence published that the medication will work for pediatrics for COVID-19. For the safety data for lopinavir/ritonavir, so this is pretty well defined given the medications used for HIV. So on the acute side, when we're first starting the medication, we can see some GI distress. So this might be something to be aware of if we're going to give lopinavir/ritonavir for COVID-19. And then there are some other chronic adverse events too to be aware of. So hepatotoxicity, pancreatitis, diabetes, QTC prolonging again, similar to hydroxychloroquine, lipid elevations, and fat redistribution. But most of these are more going to be with chronic use of the medication and not acute use if it was given for a SARS-CoV-2 infection. The other piece to be aware of with lopinavir/ritonavir is that given ritonavir is a 3A4 inhibitor, it can cause a host of substrate and inhibitor, it can cause a host of drug interactions via these cytokine P450 enzymes. So it's something that we must be aware of, and we must screen for these drug-drug interactions. One potential valuable resource if you were to have a patient started on this medication to check for any drug interactions is the University of Liverpool's drug interaction resource with a link available here for you. So how do we dose lopinavir/ritonavir? So for adults, it is dosed at lopinavir 400 milligrams, ritonavir 100 milligrams, PO twice daily. For children, there's two different recommended doses. One is more body surface area based, so lopinavir 300 milligrams per meter squared per dose twice a day, or the weight-based 16 milligram per kilogram of lopinavir twice a daily. So both of these being dosed on the lopinavir component. Then there is an approximate lopinavir dosing based on a 300 milligram per meter square dose for patients that might be able to take a tablet. So if you have a patient that falls into one of these categories, so pick the middle here, so maybe they are 25 kilograms, we can approximate their dose with the 300 milligram BID of lopinavir. So what to do if you have a patient that's too young for these tablets, for lopinavir or ritonavir. So in this case, this medication is not recommended to be crushed, and there's some data to support that this decreases systemic exposure of the medication, and that means it decreases the area under the curve by 45 and 47% respectively of the combination. So there is a commercial solution available for these patients that would require the liquid, but right now that solution is on shortage in the United States, so it can be a little bit difficult to come by, at least at the time of the recording of this video. So the last medication we're going to discuss for SARS-CoV-2 is tocilizumab. So tocilizumab is a monoclonal antibody against human interleukin type 6 receptor, or IL-6. In this case, similar to all these other medications we discussed so far, published use of this agent is primarily limited to adult patients with COVID-19. I will say tocilizumab, it is FDA approved for cytokine release syndrome, as well as various different rheumatological conditions for patients that are over 2 years of age, or at least greater than or equal to 2 years of age. So there is some data to support tocilizumab's use in pediatrics, but currently at this time there's no published data on tocilizumab in COVID-19 in pediatrics. So tocilizumab for COVID-19, for its efficacy, tocilizumab has been studied in smaller case series in China, and some of the early data showing that essentially that patients have a much marked decrease in their inflammatory response. So just pointing out on this table here, looking at C-reactive protein, before tocilizumab therapy, values reported at 75, decreased to 2.72 after day 5 of tocilizumab. So the authors' conclusions from these small case series essentially conclude that tocilizumab effectively improved clinical symptoms and repressed the deterioration of severe COVID-19. It is worth noting that tocilizumab is well tolerated, but when it's used for multiple injections for rheumatologic patients, there has been a reported increased risk of infection found in these patients over time. It's difficult to determine, or there's nothing to determine yet if we would see these increased infections, given that we're giving one-time doses of this medication for COVID-19, which leads into how we dose this medication for COVID-19. And right now, the current reported dosing in these studies is 4 to 8 milligram per kilogram per dose as a one-time dose. And then if the patient doesn't improve 12 hours after that first dose, giving a second dose. The question in pediatrics is, should we dose these patients in pediatrics higher? So currently the FDA-approved indications recommend 12 milligram per kilogram per dose if the patient's less than 30 kilograms. So I think this at least warrants the question of, is the 8 milligram per kilogram appropriate, or should we be dosing higher for some of our smaller patients? The last piece I wanted to briefly touch on is neonatal COVID-19. So cases of neonatal COVID-19 are very, very rare so far, at least in the published literature. And treatment of these patients is, honestly just a big question mark, which is what's here on the slide. So currently there's 2 agents that we could most likely dose the medications for, but if they work or if they're safe to give to neonates with COVID-19, I think the jury's still out on that. So investigational remdesivir does have dosing available per Gilead, that if the patient's at least postnatally 7 days old and they're full term, the dosing for pediatrics would be what's used here. And then for lopinavir ritonavir, there's dosing for those that are at least 42 weeks post-menstrual age, typically from the HIV indication, but we could infer from that. So in summary, right now we don't have a lot of strong clinical evidence, and we must scrutinize this evidence closely. There's currently no proven evidence-based treatment for COVID-19. I think that would, at the time of recording of this video, go for adults as well as pediatrics. I do suspect in the coming weeks to coming months we will start to see a wide variety of studies and agents being published on. So I suspect there might be some at least more evidence-based treatments coming, or at least more studies being published on the treatment of coronavirus, particularly probably more on the adult side, but I think we might start to see some in the pediatric side hopefully get published. So we might hopefully have more data to go off here in the future, but right now this is currently some of the agents that are currently being looked at, and we really must consider the benefit-to-risk ratio of these medications when used in COVID-19 in pediatric patients. All right, so thank you for tuning into this video. I am happy to take questions with my email here on the slide for you.